Thank you for joining us for this episode of McDermott, Will & Emery's Of Digital Interest podcast. Today we're joined by McDermott partners and telemedicine thought leaders, Dale Vandermark and Lisa Schmitz Mazur. Dale, Lisa, thank you for joining us. I know you both just came off speaking engagements at the 2018 ATA conference. Lisa, why don't you kick off? Tell me a little bit about what's on the minds of industry leaders today.
What we learned was really something that I think had become readily apparent to us in the past year or so, which is that telemedicine is now the standard of care. It is no longer the shiny new object or new toy that's being integrated into healthcare delivery by hospitals and medical groups and direct-to-consumer telemedicine companies. It is now a solution that is increasingly expected by patients and increasingly popular with providers, but it is part of the way in which care is delivered. So it's just becoming more of the norm. The other thing that we're seeing quite a bit of is there's an enhanced focus on engagement. So how we get patients and providers to really engage with digital health solutions to encourage the patients use these tools in their everyday lives. They are no longer viewed as additive, but instead they are increasingly being focused on as a very targeted and efficient solution for an issue like a diabetes patient, and a mobile app that's tailored to diabetics that also facilitates telehealth consultations with endocrinologists. So it's the development of solutions that are more focused on a particular disease or condition and are intended to facilitate telehealth in a way that feels natural and is less viewed as kind of like an ancillary or an add-on type service.
If I could just add to that, maybe just a slightly different way of even describing what you just described is that telemedicine services are now being thought of strategically as opposed to as some interesting thing that we might do. On the engagement piece, I think that's a great example as health systems are thinking strategically about their place in the market. They're thinking about patient engagement and really being able to build that customer loyalty that a lot of systems now want to see happening. If they can use those tools to achieve that, well, then they become part of a larger strategic thought process as opposed to just something interesting on the side that maybe someone is experimenting with or is maybe a convenience to people. And I think we're seeing that also in the treatment plans that are being developed. People are developing treatment plans that include telemedicine more naturally so that it's not, again, just something that, we can add this on as a convenience. It's becoming more a part of what we're doing on a daily basis in the healthcare sector. And I think that the Bipartisan Budget Act has helped significantly in that with the telemedicine use cases that Congress has now approved and made part of the reimbursement structure in Medicare and telestroke and in diabetes management. So I think that we can now start thinking about these tools more in a strategic way as opposed to, how do we convince people that they're useful?
And I think that the Bipartisan Budget Act, which provided for the reimbursement of the distance site provider, so the stroke neurologist who's located at an academic medical center or a hospital or some other location who's diagnosing a patient who has a stroke at a location that perhaps does not have someone with that level of expertise to facilitate an emergency room physician to diagnose and then treat that stroke. So Congress has said it makes sense for us to pay that stroke neurologist to deliver that service. I think part of the reason is they could imagine themselves showing up at a rural hospital and not having access to a stroke neurologist. So it goes back to the point of it's the standard of care now. There's an expectation that if you're a hospital without that type of expertise, that you will investigate opportunities to incorporate a telestroke program into your hospital. As lawyers, Dale and I think, okay, today we recognize that's a standard of care. Congress is now willing to pay for it. So I think the question, and I'd like to hear your thoughts on this, Dale, is what about the hospitals that choose not to have a telestroke program or that have access to a telestroke network and choose not to use it for patients who show up and don't get access to those telestroke services and suffer harm as a result of that, such as a delayed diagnosis and treatment of a stroke, which is, as you know, very time sensitive? Could that lead to increased medical malpractice suits or other types of liability?
You only want my opinion when you have very difficult questions, Lisa. It's really not fair.
That is true.
But it's a great question. It's a question, actually, I think, that we're seeing being asked in that broader digital health landscape with some of the new technology coming online, particularly the clinical decision support tools that are out there. If the tool is available and it becomes more and more easily accessible, and if there is a reimbursement model that captures it, this is some of the things we're speculating about, how much of a part of the standard of care does it become, and how risky then does it become not to utilize those things? And I think that that's a fair question to ask. Neither of us are medical malpractice attorneys, but we know that the standard of care that physicians in the facilities are held against is the standard in the community. And I think that with the advent of telemedicine, the standard of the community starts to look more and more national in many respects. And so those sorts of questions, I think, are at this point unanswerable. I mean, I think we can speculate that, yes, that increases the risk. But I think we're going to absolutely continue to see those questions coming up, and people are going to have to start thinking about them. And I think maybe a place to start with is to go talk to the insurers about it. They've embraced telemedicine as a part of their policies. What do they think about that issue, and what is their approach when they're taking a look at a facility or a physician in terms of how they practice and how they adopt telemedicine, whether they're doing the things that they really need to do to protect themselves? It's a great question. I don't think that we have an answer to it yet, but people really should be thinking about it.
Dale, I know that you talked specifically at ATA about artificial intelligence, which is also another sort of burgeoning area that people are trying to figure out. Where does it fit in this landscape, and what are the use cases? What are we learning there, and how is that playing then into standard of care as well?
Yeah, that's a great follow-on to Lisa's question. We are, fortunately, in the case of artificial intelligence, not quite that far enough along where that question is quite as ripe as I think the question Lisa asked. But it is the kind of question people are beginning to ask themselves as these technologies continue to evolve and develop, and quite frankly, as they're being put to use in products that are out there right now. And they are there. Don't kid yourself. These artificial intelligence systems are being utilized in a variety of ways. They may not be being utilized in some of the more experimental ways that we're seeing news reports about, for example, out of academic medical centers or even academic centers that have good CS departments that are developing these systems to do all these neat things. But artificial intelligence systems are being utilized all over the place in system optimization, not just in healthcare, but elsewhere. I think the first set of questions and issues that are going to come up with artificial intelligence revolve around the data that's used to train those systems. We're seeing already, outside of healthcare, but the application to healthcare of this issue is readily apparent, but we're already seeing examples of data sets that are bad being deployed with AI systems, resulting in outcomes that are not good. There have been lawsuits on the basis, for example, of public benefits being denied through an automated system that is fed bad data, and people being denied this benefit and saying, well, gee, why was I denied? And the lawsuits are demonstrating that these automated systems that are out there are not producing necessarily good results. And it really comes from the data. It comes from that starting point and that data collection point. And there's a lot of fear that these data sets, and quite frankly, the evidence is clear that at least in some instances this is the case, the data that we collect, just by the nature of how we collect it, isn't good, and that we really have to rethink in many instances exactly what it is that we're looking for and how we go ahead and collect it. Now, translate that over into healthcare. Generally, when you're talking about data sets in healthcare, you're talking about a much more curated set of data on the front end. And so those risks should be diminished, at least initially, on the front end. But what we're discovering as a general matter is you don't know what you don't know. And so when these results start popping out and they look a little bit strange, they're telling us that there may be something wrong with the data. And I think in healthcare, we have to be mindful of that and be thoughtful about the way that we start to address it when it comes to some of these systems, whether they are a chatbot, urgent care triage sort of an approach to things, or a system that takes a look at a variety of population-based data and draws conclusions about, say, what the flu season's going to look like, or systems that look very specifically at images and determine whether something looks like cancer or not. I think we need to be very mindful of the data and its quality. I think that's going to be the first big issue we see with artificial intelligence.
Dale touched on a really important point, too, which is that the electronic health record and the patient health information that's maintained within that record is structured right now. And there is a higher credibility, accuracy, of completeness associated with the medical record because of the way the systems are designed and information is stored and gathered, et cetera. we hear every day from telemedicine companies and other digital health providers that they want to take data that they gather through their apps or solutions and then have that data be interoperable and put into the medical records of patients. And the thinking is then that doctors will have a complete look at that patient's medical history. They'll see their medical information that was gathered during in-person visits, information that was gathered during telemedicine visits, but also remote monitoring data like your Fitbit or your Peapod data or your internet search history. Are you spending a lot of time researching chest pain? Are you looking at exercise routines that might help you lose weight? And so through that spectrum, you have really structured data from healthcare visits to telemedicine visits that may be with providers who have never seen the patient before, with the exception of this one encounter, like a direct-to-consumer telemedicine consult, to gathering what we call consumer-generated information, things that are gathered from, like I said, your Peapod account or your Facebook account. But the risk is, for example, I have a 3-year-old who uses my phone all the time to search for YouTube videos or plays on Facebook. I order food through my Peapod or Instacart account that's not for me but for them. And so the data, the integrity can be jeopardized. And taking that information and putting it into an electronic health record for reference by a physician may sound really great, but that's really at the heart of the concern. It's the quality of the data that's being put into what is somewhat now a sacred and protected source of medical information and potentially polluting it with data that has less integrity. And to Dale's point, that is where I think the real weakness lies with a lot of these solutions. It's if they don't have data that has that integrity, if it's, corrupted, if it's less reliable, because it's consumer-generated information that's not as accurate, it can create real problems and lead to misdiagnosis or adverse health events for patients.
So I'm curious, it's a slightly different direction than I anticipated, but I'm curious based on this conversation, things like challenges with data in AI or other new pieces of telemedicine that are coming to market, given the low risk tolerance in healthcare generally, when we start to see things like this happen, how much does that dampen the promise of telemedicine broadly, even if it is already the standard of care, in terms of how we think about, will we keep pushing forward, will we keep advancing, or will we sort of just stay where we are in the safe zone?
Yeah, why don't we all have autonomous vehicles right now, right? I would say that the bigger danger is the hype and disappointment danger than it is the quality danger. I think that one of the hallmarks of the health system in the United States is that when it comes to rolling out new service lines, when it comes to rolling out new products, we are highly regulated. And so the health systems are very deliberative and they're very careful about what they do. And so to me, we're in the best location to have these experiments occur with the lowest chance of those experiments resulting in very bad outcomes. I think it's really more a factor of how long it will take to get some of these things to market than it will kind of a backlash against it, because I do think that it really is that hype factor that's the biggest challenge. And I think we've seen that with telemedicine to a certain degree, that as that telemedicine ball started to roll, people started talking about it as the savior of all things healthcare. And, it's just not the case. There are use cases for telemedicine. There are ways that it can be more cost effective than other sorts of treatment. But there are also bad use cases for telemedicine. And there are ways that it can actually increase the costs associated with healthcare delivery. And we need to not shy away from those distinctions and I think take a realistic view to make sure that when we try to advance the ball, we're doing so in a way that it's going to stick and we're not going to see any of that backsliding.
What other things are you guys seeing coming out of ATA or generally as you're working with clients right now in terms of either the promise of telemedicine and where we think it's going, or perhaps some of the barriers to success that clients are really struggling with right now that others should be mindful of?
This is something Dale and I have explored quite extensively in light of recent events, billing and coding compliance. This is a risk area that I think we all knew existed and telemedicine providers have had on their radars and incorporated in their compliance programs since its fruition. But it has become very acute and apparent that telemedicine billing is incredibly complex. There are many people out there that say, no, it's really just you just bill and code the same way you would for an in-person visit, but there's just some additional rules you need to follow for telemedicine. I do think it's much more complicated than that. I think that the ways in which billing for telemedicine happens require special attention within the billing workflows of organizations. I think research needs to be done on the appropriateness of certain codes, when they can be used, how frequently they can be used, who can use them. them when they're designing telemedicine programs. I don't think that work is done or is given enough attention at the front end of a lot of programs, which can lead to dissatisfaction or surprise when organizations find out that something they thought was a billable service is in fact not. I think that there needs to be also enhanced attention to how organizations communicate financial responsibility for certain telemedicine services to patients, because if a service is not covered by a payer, organizations sometimes look to the patient to be the one who pays for that service. And patients often anticipate that their payer will cover telemedicine. Or
why would that patient?
Yeah. Or why would you provide it to me if it's not covered? So there's this communication that needs to happen between providers and their patients about financial responsibility and when a service is covered and reimbursed by their third-party payer and when it is not, as well as between providers and the third-party payers to understand when a service is covered, when it is not covered, and if it is covered, how do you bill for it? What Dale and I have spent a lot of time discussing lately, and this was a topic that came up quite a bit at the recent ATA event, is the OIG's report that recently came out. The OIG work plans for last year said that telehealth was going to be a focus area for both Medicare and Medicaid. The OIG fulfilled its promise and audited claims for telemedicine services and discovered an error rate of 31%, which is incredibly high. And as a result, they've identified various areas where organizations can improve so that they don't make the same mistakes that they found in that 31%. But the rules that need to be followed are very complex. And I am still myself processing what some of those issues were and why they were issues in the first place. And I think that there is an opportunity to provide comment to the OIG on why they identified those issues and to get further education and perhaps even get the OIG to correct or modify some of the issues that they identified so that they're clearer to those who are in charge of billing and coding, what needs to be done so that it is in fact done correctly.
It's interesting. They take on somewhat of a life of their own, because as you were talking, I was thinking to myself about the Medicare program. As a general matter, up until the Bipartisan Budget Act and the expansion there, the telemedicine reimbursement was really all about access. It wasn't about reimbursing for telemedicine services generally. It was all about providing people access to care they might not otherwise be able to get because of geographic distance. And it's something that we tend to forget because I think you're right. Telemedicine has become now the standard of care in many ways, but Medicare still, the basic reimbursement structure is one based on providing access to people who might not otherwise have it because of geography. And we've got to keep telling ourselves that when we think about Medicare reimbursement. So then when we take a look at the rules, they have all of these components to it that relate to that issue. And we need to dot all those I's and cross all those T's and get to it. The recent MedPAC report certainly didn't suggest that CMS go ahead and change those rules and expand the program significantly. So they're still focused in that way, even as it becomes more mainstream. I think it is something that we need to always have in the back of our head that outside of those special programs, we need to be thinking about this in terms of that geographic component, because that's where a lot of those foot faults were that OIG reported. I think it's also important to note that the data set that the OIG used was, I think, from 2015, and the amount of reimbursement associated with telemedicine in 2015 was, I think, $17 million.
It's like a rounding error.
Which is a rounding error at best in Medicare. Now, it does represent, I think I took a look and I did some quick back-of-the-napkin calculations, and it does look like the rate of growth in telemedicine reimbursement has been about 50 to 60% per year. So it is growing at a very rapid pace. And so it doesn't take too long, not too many years, before that reimbursement amount starts to be a significant amount. And so that 30%, 31% error rate becomes a lot more significant in the eyes of people. And I think the attention that OIG is giving it should be a wake-up call to people and to organizations that maybe have not focused on this as much because it is such a small part of their own reimbursement. I mean, that $17 million is minuscule for, say, a 5-hospital health system that has $1 to $3 billion in revenue. What's 17 million out of all of that? It's a tiny amount, but we know that OIG is focused on it. So now here's an opportunity to spend a little bit of resource on this, get this right, so that going forward, you don't create the workflows that are systemically problematic that you have to go back and fix later on. It's a good idea to make sure you get it right now.
I think that's exactly right. It's interesting because the amount that's being submitted to Medicare is so low. Many of our clients will ask us, well, why even bother? Why just not bill for it then? Just do it for free. Because the reason that organizations do this is because it saves them a lot of money. So to run a tele-ICU program, to have a physician located remotely who can monitor ICU patients hundreds at a time, saves them from having to employ a number of doctors who deliver that same service in person. It saves money. But there aren't many codes that you can use for tele-ICU, and the ones you can use, there are severe limitations on the frequency of its use. But the Medicare rules state, if you are a Medicare participating provider and you provide a Medicare covered service to a Medicare beneficiary, you have to bill for it. You can't just not bill for it or deliver it for free. Otherwise, it could potentially be a violation of the civil monetary penalties rules with respect to patient inducement prohibitions. It's a violation of your obligation as a Medicare participating provider. So on one side of things, you're required to bill Medicare if you deliver these types of services, even if you don't want to charge Medicare for it. You don't want Medicare to pay you for it. You just want to wipe your hands of it. But on the other side of it, if you do it and you don't follow the rules exactly right, there's risk exposure. It could be a false claim.
Right. And if you don't do it on a regular basis, it's going to cost more to figure out how to do it than the reimbursement you're going to get. Yeah, it's definitely a rock and a hard place moment. But hopefully as it gets more mainstream, we'll see more and more focus on it.
Let's spend our last couple minutes talking about what we think is really going to fuel telemedicine in the year ahead or the few years ahead and how that impacts companies playing in the space today. What are our thoughts on that?
The Bipartisan Budget Act has opened up telemedicine to reimbursement in some specific use cases that I think will expand dramatically the use of telemedicine in those specific settings, but I think in an important way. One is the telestroke programs. Well-run telestroke programs can be fantastic in terms of the quality of the care that's given to patients. It can have a very significant benefit to those patients, which has long-term potentially a cost component that makes it worthwhile. So it hits all the right boxes. You can check off better quality care, better access to care, overall lower cost of care because you're making sure people don't suffer the worst consequences of having a stroke. The other programs I think are a little bit different because their reimbursement is focused on essentially substituting office visits. This is a very broad generalization, but substituting office visits for a telemedicine visit. And I think there you're going to build familiarity and you're also going to build the evidence case for potentially telemedicine in other sectors. And so I think that even though you didn't see with the Bipartisan Budget Act the overall reduction in the geographic restrictions that are in place or dramatic expansion of what services will be included more generally, I think that these changes will continue to build that familiarity in a variety of settings of how telemedicine can be used and used effectively, and that will be a real benefit. The other case is that we tend to focus a lot on government payment programs, but private payers are paying for telemedicine, and the programs they're rolling out increasingly include that as a part of what they're offering out. That builds consumer familiarity. One of the problems with digital health more generally out there, and this is true of telemedicine, is just usage. The usage is very low, but the more opportunity we have to access telemedicine, the more we use it, the more we get familiar with it, the more we are going to use it and continue to use it. So the playing field, while perhaps not perfect for what we would like to see, is definitely better than it was, but also, in my mind, the right kind of playing field as a general matter when we're balancing our goal of seeing telemedicine successful, but I think more importantly, seeing our payer community making the right decisions with respect to what products and services it will reimburse. So what I tell people all the time who come and complain to me about Medicare is, I'm a taxpayer, I pay into that system. I don't want my money going to things that don't work. I don't want to see Medicare increasing its cost without some concurrent benefit. And so that go slow approach and that careful approach to me is the responsible approach to take. And I think that the use cases are there, the evidence is there to be developed, and I think that the government will respond to the appropriate use case, particularly if they start to look beyond Medicare. And what I mean by that is some of the use cases we see with telemedicine, some of the benefits, particularly on the economic side, don't flow back to the Medicare program. They may flow back to a Medicaid program or out of the taxpayer's pocket otherwise. but not necessarily to the Medicare program. So from Medicare's perspective, if there's not that financial benefit to Medicare, their inclination is to say, well, it's just a cost and there may be some other benefits to it, but it's just an increase in cost. If they take a little bit broader perspective on that financial benefit, which they're beginning to do here and there, then I think it'll be easier to prove those use cases out.
Lisa, what about from your perspective?
I completely agree with everything Dale said. But one point I think that is a driver, and it's for me personally, I think the reason I use telemedicine. So Dale, don't answer this question. But listen, what do you think is the biggest space in a physician's office? Like, where's the biggest area?
The waiting room?
Yes. Yeah. The waiting room. People are sick of waiting rooms. Mm-hmm. It's inconvenient. It's frustrating. We're busy. Moms work full-time jobs. Dads work full-time jobs. Kids are in school. They pretty much have full-time jobs. So everyone is really busy. And telemedicine is a very convenient solution for getting people in front of a doctor without having people miss work or school or other really important parts of their lives for things that don't require
unnecessarily
an unnecessary trip to see a doctor. And with value-based care, and doctors receiving capitation, fixed amounts to treat people by payers, and that is the amount of money that you get to provide the care that's needed. It makes sense for them to try to better manage care, to keep their patients happier, to feel like their doctors are available to them, not just during their Monday, Tuesday, Thursday office hours between the hours of 12 and 4 p.m., which is when everybody is supposed to be at work or school. So it's intended to reach people in a way that makes sense for them, whether that's a mom at a soccer game on the sidelines, or it's a dad in the airport, or it's even a kid at school. With the growth of school-based programs, we're seeing that allows kids to stay in school, which is really important as well for obvious reasons. So I think consumer demand and expectations that instead of having us wrap ourselves and tailor our lives to healthcare will adapt like every other industry and fit around our lives and integrate within our schedules. Will continue to be a real driver of telemedicine. And
is it too much and too far to say that you see telemedicine going the way the cable companies go, right? They're going to start to actually come to us instead of us waiting from 8 to 6 to see them.
Well, it's interesting because if you look at surveys of individuals of where they rate their cable company versus their payer and their healthcare provider, they're all pretty on par right now. Yeah. And so hopefully healthcare providers will recognize that they need to start eliminating their waiting rooms and start treating their patients a little bit more like customers. And as they increasingly receive value-based reimbursement and patient satisfaction scores and utilization and other tracking mechanisms that are in place to monitor and track physician performance become more prevalent and popular, I think what we're going to see too is that telemedicine becomes an increasingly important solution to balancing all of those objectives.
I think also that notion of consumer empowerment that has reiterated every 5 years or so in healthcare or whatever it is. I don't know about you, Lisa, but I think that there has been a change recently, and that the power of the consumer to change the dynamic in healthcare is finally now finding leverage, right? There's a foothold there. And I think that it's coming through tools like telemedicine, but some of the other digital health tools, as well as the creation of, I'll call them, it's probably not the right way to describe them, but alternative health insurance companies like Oscar that are offering up to consumers things that you can do in your banking, you can do in just about any other aspect of your life you never thought might be available to you in terms of your healthcare. And I think as those examples continue to proliferate, that these things, these annoyances, these headaches about healthcare that we've been dealing with for as long as I can remember, and as Lisa will gladly tell you, I'm heading close to Medicare age. These things that seem to have no solution now appear to have solutions, and that those tools are becoming more and more available. That will put the pressure on the institutional healthcare players that are out there that have been forever and that are really still the central part of healthcare delivery. It's going to put pressure on them to start changing and start addressing those things, whether it's the early check-in procedures, the electronic check-in procedures, better automated systems, those tools, those devices, telemedicine are all both those leverage points, but also they benefit from the value that they demonstrate that the consumer really can begin to expect from the healthcare industry.
Thank you both for the lively discussion. I'm sure we're going to continue to talk about telemedicine in the weeks and the months to come. Thanks again to our guests, McDermott partners Dale Vandermark and Lisa Schmitz Mazur. We encourage our listeners to share their thoughts on this telemedicine topic by visiting our blog at ofdigitalinterest.com. You can also take a deeper dive into digital health trends, opportunities, and legal implications by subscribing to this Of Digital Interest podcast on iTunes or SoundCloud.
Copyright 2018 McDermott, Will & Emery. All rights reserved. Any use of these materials, including reproduction, modification, distribution, or republication, without the prior written consent of McDermott, Will & Emery, is strictly prohibited. This may be considered attorney advertising. Prior results do not guarantee a similar outcome.